thank you very much for the opportunity to participate in this nice meeting and to be able to share with you our experience to date developing CAR T-cell therapy for childhood solid tumours. These are the disclosures for this presentation. And what I will start off with doing is showing you our results to date of a phase 1 clinical study using GD2 CAR T-cell therapy for refractory and relapsed neuroblastoma. So neuroblastoma poses a major challenge in pediatric oncology. It's the most common solid tumor in children after brain tumors, with an annual number of new diagnoses of 1,200 within Europe. It's an embryonal tumor that arises from the sympathetic nervous system, and it commonly presents as an adrenal tumor or a paraspinal tumor, and then it can metastasize to the bone and to the bone marrow. Over half of patients diagnosed with neuroblastoma have high-risk disease, and the standard of care of treatment for these patients is a multimodal intensive treatment regimen including high-dose chemotherapy with stem cell rescue. And despite this maximally intensified treatment regimen, less than half of these patients are long-term survivors. And as you can imagine, there are significant late effects associated with this treatment regimen as well, indicating a clear need for developing new treatment approaches. So to develop CAR T-cell therapy for neuroblastoma, we use GD2 as a target antigen. So GD2 is a dicellular ganglioside. It has a carbohydrate extracellular domain. And it has a lipid tail that anchors it into the membrane. It's abundantly expressed on virtually all neuroblastomas, and importantly, the expression is extremely limited in normal tissue, with dim expression only in normal neurons. We already have extensive experience in targeting GD2 using antibodies, which is now part of standard treatment for patients with neuroblastoma. But relapse of disease remains a major problem, and targeting GD2 with a CAR T-cell approach may induce durable immunity and hence prevent disease relapses. So there's 2 previously published studies of GD2 CAR T-cell therapy and neuroblastoma. And both of these are shown here. Each of these use the GD2 antibody called 14G2A in their CAR design. And this is the same antibody that is used in GD2 antibody therapy. The first study, shown on the top, used the first generation CAR design without lymphodepletion and cell doses up to 2 × 10⁸ per meter square. In this study, there was no dose-limiting toxicity, there was no neurotoxicity, and in 11 of the patients that were evaluable for tumor response, 3 complete responses were reported. And subsequently, in the next study, the same CAR was used, but now in a 3rd generation design incorporating both CD28 and OX40 as co-stimulatory domain. Here the patients now receive fludarabine and cyclophosphamide as conditioning and cell doses up to 10⁸. Again, there was no dose-limiting toxicity and no neurotoxicity, but despite in vivo expansion of the CAR T cells, the responses as seen in the first study were not recapitulated with stable disease as best clinical response. So here the GD2 cassette is shown that we've used in our study, and I will highlight some of the main features. So the binding domain used in this CAR is derived from a novel humanized GD2 antibody called K66, so a different antibody to that used in GD2 antibody therapy. The spacer for this chimeric antigen receptor is derived from human IgG1 with the mutations of the Fc receptor binding sites. And it's a 2nd generation chimeric antigen receptor incorporating CD28 and CD3 zeta signaling domains. And using a 2A sequence, every CAR T cell that expresses the GD2 CAR T chimeric antigen receptor co-expresses a suicide gene called RQR8, which incorporates the epitope for rituximab, which will allow us to delete these T cells in the event unmanageable toxicity would occur. And this cell product is referred to as 1RG CAR T, referring to the RQR8 and GD2 CAR components. So So this is the manufacturing process for these 1RG CAR T cells, which is a standard process with a retroviral vector starting from non-GM-CSF leukapheresis as starting product, with a manufacture period of 7 to up to 10 days for the 10 to the 9 cell doses. So the study objectives are to determine the feasibility and the safety and tolerability of 1RG CAR T cell treatment. Patients eligible for this study are children over the age of 12 months with relapsed or refractory neuroblastoma who have at least one site of evaluable disease, and we excluded patients with CNS involvement because of the low level of GD2 expression in the central nervous system. So the study is a modified rolling 6 design. So the first 3 cohorts, the patients all received 10 to the 7 per meter square CAR T cells with increasing amount of lymphodepletion, starting from none to cyclophosphamide only to a combination of cyclophosphamide and fludarabine. Then going forward, cyclophosphamide and fludarabine conditioning is continued, but now increasing the cell dose to 10 to the 8 and 10 to the 9 per meter square for cohort 4 and 5. So we've been successfully manufacturing CAR T cells for all 14 patients enrolled on this study to date and obtaining sufficient cell numbers for the 10 to the 9 per meter squared cell doses with a median transduction efficiency of 33%. These CAR T cell products have a favorable immunophenotype. The majority of the cells are central memory cells with some smaller population of effector memory and naive cells, a mixture of CD4 and CD8 CAR T cells, and a limited upregulation of PD-1, LAG-1 and TIM3 as compared to the non-transduced counterparts, indicating CAR T fitness. For 4 of these patients, we were able to look at cytolytic activity against autologous neuroblastoma tumor cells as infiltrating in the bone marrow. So an example is shown here on the left, where we incubated bone marrow infiltrated with neuroblastoma tumor cells overnight with the patient's own CAR T cells, and you see near complete elimination of the neuroblastoma tumor cells. To date, we have enrolled 15 patients on this trial, all patients with refractory relapsed neuroblastoma, all of them receiving at least 2 to up to 5 previous lines of treatment. These patients have soft tissue sites of disease, bone sites of disease, in most cases multifocal, as well as bone marrow involvement. Of the 15 patients, 1 patient did not undergo leukapheresis, and for 4 patients we have successfully manufactured 1RG CAR T cells, but patients were not treated due to disease progression. So in the first 3 cohorts where the patients received 1 times 10 to the 7 per meter square of CAR T cells with increasing amount of lymphodepletion, we have not seen CAR T expansion. So in the absence of dose limiting toxicity, we used an accelerated dose escalation design with just 1 patient in cohort 2 and cohort 3. In contrast, in cohort 4, where the patients received 10 to the 8 and 10 to the 9 per meter square CAR T cells, we've seen CAR T expansion in all 3 patients. And this was in the absence of dose-limiting toxicity or neurotoxicity. And in 2 of the 4 patients treated on those dose levels so far, we have seen anti-tumor activity. And I will discuss these patients in more detail. So here the in vivo expansion of CAR T cells of the 3 patients treated on cohort 4 is shown. So here you see a limited expansion of the CAR T cells for patient 11 and patient 12 with a marking up to 6,000 and 8,500 copies per microgram. And both these patients had disease progression at the day 28 assessment. This in contrast to patient 10, where we saw a 10-fold higher in vivo expansion of CAR T cells with a marking level of up to 50,000 copies per microgram on day 14. And I'll discuss this patient in detail. So this patient was an 8-year-old girl with relapsed metastatic neuroblastoma who had multiple lines of previous treatment. And at trial entry, she had widespread bone metastases requiring opioids to manage her bone pain. She had extensive marrow infiltration with neuroblastoma, and her performance score was 60%. So 5 days after receiving the CAR T cells, this patient became febrile with associated hypotension requiring fluid resuscitation. At the time you see an increase in her CRP in red, as well as elevated levels of IL-6 and IL-10 indicating a cytokine release syndrome. So this patient was treated with tocilizumab on day 6, and after that the symptoms are rapidly resolved. And subsequently, in the second week after CAR T-cell treatment, from day 7, this patient developed tender hepatomegaly with ascites and weight gain. And at this time, she had a raised ferritin, a raised soluble IL-2 receptor, and raised triglycerides, indicating a macrophage activation syndrome. These symptoms were managed supportively and resolved by day 22. Then following on from there, from day 21, this patient started to develop back pain, and she again became febrile. And these clinical symptoms coincided with an increase in her LDH and associated hyperphosphatemia and hyperkalemia, biochemistry markers of tumor lysis. Again, we managed this with supportive management, and these symptoms resolved. Then at the day 28 assessment, we see this patient had a marked improvement in her performance status from 60% at baseline to now 90%. She was now pain-free and did no longer require opioid analgesia for her pain. Here you see the bone marrow aspirates on the left-hand side at baseline, which are markedly infiltrated with neuroblastoma tumor cells, and in sharp contrast on the right-hand side, the day 28 assessment, you see a small area of viable neuroblastoma tumor cells, but otherwise the bone marrow is effaced with necrotic tumor tissue. This patient also underwent an MIBG scan, which is a scan standardly used for assessment of treatment in neuroblastoma, showing the uptake of the noradrenaline analog MIBG. So at baseline you see widespread bone marrow metastasis reflected by the uptake of the MIBG throughout the skeleton. And then if you look at the day 28 repeat of the MIBG, you see a marked reduction in uptake of the MIBG isotope, in particular in the spine and in the pelvic area. And this is further demonstrated by the co-registered SPECT-CT images, where you see at most levels of the lumbar spine a reduction in the radioisotope uptake. So this patient had a pre-existing limited bone marrow reserve and also a marked infiltration of the bone marrow with her neuroblastoma. So unsurprisingly, she had profound lymphopenia following the lymphodepletion conditioning. She then had a apparent recovery of her neutrophil count at day 20, but subsequently she again became pancytopenic and highly blood product dependent. She had a further bone marrow aspirate at day 45, which showed hypoplasia and an early evidence of neuroblastoma regrowth. We checked the expression of GD2 on the tumor cells, which was still there, and at the time, although the marking levels were decreasing, we could still detect the GD2 CAR T cells in the blood. Then sadly, in this patient with prolonged and profound neutropenia, she died at day 50 after CAR T cells because of Pseudomonas septicemia. So then in the absence of dose-limiting toxicity, we proceeded to cohort 5 using 10 to the 9 per meter square of CAR T cells, and so far we've treated 1 patient on this dose level. And this is a 10-year-old girl with relapsed localized neuroblastoma, who at the time of enrollment in the study had a local regional collection of lymph nodes, shown here on the MIBG scan, but no metastatic disease and a performance score of 100%. This patient received 10 to the 9 per meter square of CAR T cells as a split dose, and here you see the marking at a maximum of just over 3,000 on day 14. This patient became febrile 12 hours after the first dose of CAR T cells, but remained normotensive. You see an increase in CRP, but only mildly elevated IL-6, and she was managed with supportive care. Here you can see the tumor site at baseline in the top left, and you see by day 9 you can start to see signs of inflammation followed by desquamation on day 24. And then quite a while later in the clinical course we see marked infiltration over the midline component of the tumor at day 56, which resolved without any intervention by day 63, and on clinical examination a marked reduction in the midline component of this tumor. So here you see an MRI scan and MIBG scan at baseline. So you see the cervical tumor, which is MIBG avid. Then at day 28 post-CAR T cells, you see a reduction in the midline component of the tumor, which is now taking up less of the MIBG. However, you see progression of disease right laterally, as well as a new lesion appearing here on the left. And going forward 2 months post-CAR T cells, you see a continued response in the midline component, which is now no longer MIBG avid, but progression of disease at the other side. So really indicating a mixed response to CAR T cells. So we then biopsied these different sites of persistent disease as well as the residual mass in the midline. And you can see that at the sites of persistent disease you see viable tumor throughout in each of these biopsies, whereas the residual lesion in the midline shows a large area of necrosis. So conclusion so far from this study is that we had 100% manufacture success of making CAR T cells at doses of up to 10 to the 9 per meter square, were safely administered with no dose-limiting toxicity and no neurotoxicity. You see in this setting of a childhood solid tumor some significant cytokine release syndrome and biochemical signs of tumor lysis. And importantly, in 2 patients we've seen anti-tumor activity in bone, soft tissue and bone marrow sites of disease. And we continue to recruit patients on this study to complete the cohort 5, treating at 10 to the 9 per meter square. So now for the last part of my talk, I just want to slightly change gears and show you some other work in progress in the area of CAR T cell therapy for childhood solid tumors. And one area we're looking at is see if we can apply CAR T cell therapy to other childhood solid tumors that have a high unmet need. And an obvious area of high unmet need are childhood brain tumors, which are the most common cause of childhood death because of cancer. And one particularly hard to treat childhood brain tumor is DIPG, or diffuse intrinsic pontine glioma. It's a tumor, as the name indicates, that is located in the brain stem, and there is no curative treatment for this tumor to date. So all these patients are treated with palliative radiotherapy, but the tumor inevitably progresses, and the patients have a median overall survival from diagnosis from about 9 to 15 months. So we and others have shown that these tumors consistently express GD2. So here for reference you can see in 2 primary neuroblastoma tumor samples the GD2 expression, and here on the right you see a similarly high expression of GD2 in 7 different DIPG neurospheres. So our ongoing work is now in testing a GD2 CAR T application for DIPG tumor cells, and here just a small example of that. On the left-hand side you see in blue the CAR T cells, and in red the control CAR T cells. You see cytolytic activity on the left of the control target cell, which is GD2 positive, and then in the middle and the right you see clear cytolytic activity against the DIPG neurospheres. So with this work, we're working towards an early phase clinical study, and here the initial clinical study design is shown. So what we are planning to do is co-express in this cassette with the GD2 CAR a rapamycin-activated suicide gene that crosses the blood-brain barrier and would allow us to delete these CAR T cells in the event of toxicity. We plan to treat patients with DIPG in a post-radiotherapy phase, at which time the tumor is quiescent and not at that time actively progressing. And the aim of the study is to explore a safe dose as well as the optimal route of administration, looking at both an intravenous administration route or an administration route intraventricular, i.e. directly into the CSF. And a second area I wanted to mention is really the work required to identify the barriers that there are for preventing persistent CAR T cell function in these childhood solid tumors. And this is a model that we have been using in neuroblastoma to study what these barriers may be. It's a transgenic model, double transgenic for both MICAN as well as the mutated ARC, which makes it constitutively active. And both these are under a neurocrest specific promoter. So here on the Kaplan-Meier curve in pink, you see 100% penetrance of this tumor in the mice with a very aggressive behavior. Importantly, this disease recapitulates the human disease, both clinically as well as morphologically, and these tumors express both GD2 and ALK, which can be used as targets for T-cell therapy. So we have made a murine equivalent of the GD2 CAR T-cell, CAR T construct co-expressing luciferase to allow us to track these CAR T-cells in vivo. And in these mice we can then monitor what happens to the tumor with MRI. And that's shown here for 2 mice that were treated with GD2 CAR T-cells. So at baseline you see the tumor labeled with a T centrally with the kidneys on either side. Then at day 7 and day 14 you see that the tumor is no longer visible on MRI. However, at day 21 the tumor regrows with subsequently an aggressive progression of the tumor. And then if you look at what happened to the CAR T cells, you see engraftment of the CAR T cells, localization to the tumor day 3. The signal is still there at day 7, but you lose your signal at day 14, explaining why the tumor shows progression at day 21 on the MRI scan. So this model very much recapitulates what we've seen in a clinical study where we see clear anti-tumor activity, but so far that has been transient. And this provides hopefully a useful model to work on next generation approaches. So what they could be is they could either be combination with other agents, for example checkpoint inhibition, or agents that may delete or re-educate myeloid-derived suppressor cells or tumor-associated macrophages. And we're similarly working with our SME partner to test next generation GD2 CAR constructs that can incorporate additional signals such as a cytokine signal or incorporate dual checkpoint and TGF-beta resistance. In this model we will be able to evaluate the benefit of targeting more than one antigen. And fortunately in neuroblastoma, in addition to GD2, ALK, B7H3 and glypican-2 have already been identified as suitable antigens. And for most of these we have a CAR design in development. And then lastly, just to highlight the importance of identifying further suitable target antigens for childhood solid tumors, because for many of the other solid tumors that we would like to target, these are not yet available. And here we're very much working on a platform to identify and discover new antigens using a single-cell transcriptomic approach and studying really these tumors in the context of normal development with the hypothesis that there may be aberrant expressed fetal antigens in this context that may provide suitable target antigens for CAR T-cell therapy. I'd like to finish with acknowledging the many people involved in that work, the people in my group, the people within the larger UCL CAR T-cell program, the clinical and research team in Great Ormond Street Hospital, the sponsor for the clinical study Cancer Research UK, and most importantly the patients and families who have participated in the study. Thank you.
Okay, so the paper is open for discussion. For those of you who are worried about time, unfortunately Dr. Doughty couldn't make it, so we have plenty of time for questions.
Yeah, Peter Bauder from Frankfurt. I'm wondering about the side effects of this anti-GD2 treatment. So knowing it from the antibody treatment, so many of these children are suffering substantially of pain and need high doses of analgesics. You didn't mention this, so...
No, it's a good question, and you're right that in the context of GD2 antibody therapy, pain syndrome has been one of the known side effects. So that was something we considered when we designed the clinical study, and that's one of the reasons why we incorporated the RQR8 suicide gene. Fortunately, though, we have not seen evidence of neurotoxicity or pain syndrome in these patients. And similarly, I was very encouraged to see yesterday when my colleague, Professor Locatelli in Italy, presented his data and saw some nice anti-tumor activity in the absence of neurotoxicity. So I think that's very encouraging.
Should have asked this to him as well. So, but I can't explain. So using the antibody, we start the infusion and the children have immediately pain, and this pain stops only if we stop the infusion. So why doesn't this happen in a neuroblastoma?
The problem with this pain syndrome is that the mechanism behind it is not very well understood. So there's several explanations, I think. One of them may be that it's actually an antibody-specific phenomenon, and some suggestions have been made that complement fixation is an important component of this pain syndrome. The other explanation may be the threshold at which CAR T cell activation happens. So the CAR T cells may not get activated in the presence of a low level of GD2 expression, but they do get activated in the context of the much higher level of GD2 expression on the tumor cells.
Peter, just to address your question and also to share with the people in the room, in our cohort patient experience, bone pain sometimes requiring not only morphine, but also sedation with midazolam. Just yesterday, a patient of ours required to be treated with both drugs for controlling the bone pain.
Probably a question regarding your higher doses. You mentioned for 10 to the 8 and 10 to the 9 per square meter that you clearly see expansion in vivo. How fold was it and how long was it lasting?
It may be easiest to go back to the slide. So the expansion is transient, and most peak expansion is at about 14 days post CAR T cell infusion. And the maximum, sorry, this will take too long, but the maximum marking levels we achieved, for example, in patient 10 was up to 50,000 copies per microgram.
Oh, okay.
Yeah.
So in this patient, the primary tumor went away, but you have a tumor on the second side, like the slide before. So apparently the CARs are there. You have the CAR T cells still there. So why do you think the tumor, just the secondary tumor?
I can't hear you very well, but I think you're asking why the tumor, different components of the tumor are responding differently to the CAR T cells.
Exactly.
Yeah, I think that may explain that this is a heterogeneous tumor, and that the tumor microenvironment in one side of the tumor may not be identical to that in other parts of the tumor. And for some reason, the CAR T cells are able to mount an effective immune response in the midline part of the tumor, whereas that's not the case in the more lateral sides. And I think here key will be to obtain tissue from these patients and study that in great detail to have a better understanding of what it is that prevents persistent T cell function.
Okay, thank you so much again.